Until now, posterior composites have been essentially prepared and restored as if they were white amalgams. We even saw a brief push toward packable composites, and those were a real disappointment. In 2007, we published an article introducing the Clark Class II. This was a dramatic transformation and change away from the old system. The cavity preparation, the matrixing, the injection molded process of restoring teeth, the biomimetic approach with rounded profiles instead of flat interproximal areas is a real change. So instead of trying to amend the old system, we simply threw it out altogether. In the article that I wrote, which detailed the new Clark Class II restoration, I described how the traditional cavity preparations and the current matrix systems are simply the old amalgam mindset with some superficial modifications. We have multiple problems with the current system. Probably most importantly is the tooth fracturing from the current cavity preparations. We have another big problem. As we fill from gingival to occlusal, we have voids and seams in between each layer. We have a problem with poor contacts because of the current matrix systems don't allow the composite to swell the way amalgam did. The wedges cause black triangles between the teeth. And finally, we have lots of problems with microleakage, especially at the margins. So in an attempt to remedy all these problems, like I said, we threw out the old system and started fresh. So I'm very excited for you to try this entirely new system. And so this matrix system and interproximators are simply an offshoot of that research. So let's go ahead and take a look at how the system works. Let's start with a clinical Class II case. Christy had incipient distal caries on her upper second bicuspid. Part of modern composite dentistry today is careful management of soft tissues. We also like to lightly stretch the periodontal fibers while we are preparing the tooth. We accomplish both goals with the use of an old-fashioned wooden wedge placed preoperatively. So before I begin to prepare the tooth, my assistant will place the pre-wedge. Instead of cutting the boxy-shaped preparation that we used to cut for amalgam, I will be cutting a saucer shape that looks a lot like the preparation style that is common for anterior composites. One of the goals of the new Class II is to treat it more like a porcelain veneer, where we really clean the surface of the tooth and create large areas of enamel to bond to. One of the things that happens with all composites is that they begin to flow a little bit past the finish lines. In the past, that's been part of the problem, but today we're going to turn that into an advantage. These areas just past the margins are typically covered with a tremendous amount of biofilm. That's why this aggressive cleaning process is so important for the modern posterior composite. So one of the things that I do after I finish the preparation is to clean the area aggressively with a lightning strip. Here I am placing a BioClear average flat molar matrix. The bicuspid matrices will be available soon. Now I am placing a thin interproximator. For bicuspids and anteriorly, you can hold onto the handles of the interproximator with your fingers. In more posterior applications, such as for molars, you'll want to use the little microhemostats, or cotton pliers, to grab the ends of the interproximator. Notice the unique adaptation of the anatomic BioClear matrix combined with the delicate pressure of the interproximator. Now I'm ready to etch. As an optional treatment, you can go ahead and put a little bit of liquid etch first because it's a little bit less viscous than the gel, and we're going to get an etch a little bit further past the finish lines. Once again, this is optional. Now I am placing the lightly filled bonding agent, which happens to be Optibond Solo Plus, with a micro applicator. I will go ahead and air thin the resin and then light cure. For total edge techniques such as I'm incorporating today, I'll go ahead and place a second layer of bonding resin over the dentin to get a superior dentin bond and to reduce potential post-operative sensitivity. We'll air thin again and then cure a second time. Now that the dentin has been taken care of, we're going to move to injection molded composite dentistry. This is very exciting. Now I am going to place the final application of bonding resin. We're going to air thin the occlusal very aggressively, but I'm going to leave a slight reservoir down on the gingival margin. This is because we're going to inject our flowable composite directly into that reservoir. This is the key to eliminating voids and gaps along the margin. I'm going to fill the saucer area about 1/3 full. The next step is to take paste composite and inject it into that reservoir that we have just created. You will notice here that the matrix is expanding nicely with the pressure. You'll notice that most of the unfilled resin and the flowable composite are being extruded laterally, and that's exactly what we want. Notice that we are using 2 curing lights. With high-intensity lights, the tooth begins to build up heat. Once I have cured the composite, I'll need to cut the interproximator away. So after about 4 or 5 seconds, I like to go ahead and apply air to keep the tooth cool. For the first time in a Class 2, the entire system is translucent. So we're going to get through and through curing. The contact is generally far too tight to be able to pull the interproximator out through the occlusal. Many of the details of finishing and polishing are explained carefully in the long version of the Dentiform video that you'll find later on in the menu. These post-operative views demonstrate the use of modern composites, modern cavity preparations, and a modern matrixing system that finally brings everything together for a great outcome. For large restorations, deep restorations, or any time that the papilla makes it difficult to place an interproximator, you can always use a wedge to retain the bioclear matrices. The deciding factors are always, number 1, will the interproximator lock itself under the contact, and number 2, is the preparation small enough to keep the interproximator from collapsing into the matrix. If either of these issues are a problem, then try a wedge, or better yet, one of these new hollow wedges, along with the new V3 ring separator from Triodent. For posterior teeth, such as this bicuspid, it is helpful to bend a contra angle on the tab, and then place the matrix on the tooth. Later on, you can bend the tab straight, or even backwards, to get it out of the way for composite placement. Here I am modifying a hollow wedge to reduce the chance of creating a flat spot on the matrix. In the near future, BioClear will have superior wedges and separators for these difficult cases, but for now these will work very well. Notice that I am removing the wedge, repositioning the matrix, and then replacing the wedge to make sure that everything is deep enough. In this particular case, I was also preparing a crown on the neighboring tooth, so the contact was artificially difficult to reach, but it is a good demonstration of a difficult contact and a deep, large preparation where an interproximator would not have worked well. One of the nice things about using these new separators is that you can actually shift the matrix because the separating ring provides tension. You can take an instrument and aggressively pull the matrix to close a difficult contact. Once the separating ring is removed, you will need to light cure again because the separating ring blocks the buccal lingual curing.